Chapter 6, let's go over our abdominal disorders. Again, our learning objectives in an organized fashion. Let's go ahead and identify and treat any immediate life threats. Again, in an organized fashion, obtain an accurate history, perform an examination, and to formulate a diagnosis. In an organized fashion, to continue running with this diagnosis, create a differential diagnosis list and then refine that list as we monitor and go through our cases. Now we know that the upper and lower GI tract is delineated by ligament traits, but you know, when we think about it as we go through, we're looking at if they're having a type of bleeding in the GI tract, that some of this bleeding is either going to be more of a red in color, come in the upper time size when we have hematemesis, or it's going to be digested blood and look more like coffee ground emesis. Now, as it moves down through the GI tract, out of the stomach and small intestines, and then out through the bowel, we look at that digestive blood becoming more black and melanic type stool. Again, we can have bleeding in the lower GI tract, causing the stool to be very blood tinged and red like, and so have hematochezia. Now, don't forget that we can have blood that is more than just stain, but around the stool that could be as a result of a large and irritated vein from the rectum as a hemorrhoid. Let's remember that we have the different quadrants, and over those different quadrants we'll have different medical emergencies. There is going to be some referred pains up to different areas that may indicate that it could differentiate between our different organs and our different medical emergencies. Here it is showing us a diagram of what areas we're looking at. And so as we do our exams and we run through our cases, we want to try to figure that out as they go into the hypogastric and the pubic area. The pubic and the pelvic girdle. We're looking at lower quadrant abdominal pain. We can remember to put in the female issues as we move through these cases today. But these would be other ones that form into our medical diagnoses as we move through. Let's take a look at our first case here and our dispatch. We're dispatched to a 40-year-old female with abdominal pain. She's definitely still within childbearing years. I'm not exactly sure where we're going as far as location and you know, the type of female, where this is at, but all we know is that, you know, we just have a very simple complaint from dispatch and the reporting party. We're going to use our AMLS pathway to keep us organized fashion as we go through the case. And is the scene safe? Where we have to determine as we roll up to the patient's house, do we see that anything here is going to be of an issue? Decide what PPE we're going to take on, and we move into our case. So here we see our patient. It does look like from this look that, I don't know, the shirt may be forward. She could be pregnant. We're not really sure. She does look like she's vomiting. Is this, if this is pregnancy related, then is this just a hyperemesis gravidarum, or is this just regular morning sickness? What trimester? What's going on? At least the patient is awake and is able to maintain their body posture. Hopefully, they're able to then communicate with us. But we should note that at least airway, breathing, circulation potentially is intact, as well as our LLC. So we're going into our initial observations. She's 40. She appears to be in some pain. She vomits. We can take a look and see what's in the toilet to see what color is the vomit. Is there anything else? But now remember, as she's telling us where in your belly does it hurt, so we can locate that and then describe that pain. What does it feel like? Let's dive into a little bit more as we consider other things that might be going on. She's awake. Open, respiratory rates 40, everything seems to be okay. So is there any blood in the stool, in the vomitus, any coffee ground emesis? Is this only food products? What else is going on? Is this just GI, or is this GU? Is this reproductive? Is this musculoskeletal? Now, we got a patient that seems to be sick, and we're going to be transporting. Now, what is our differential diagnosis? What could it likely be? Again, we were throwing out a lot. It could be just a stomach kind of virus to morning sickness. It could be cholecystitis, an ulcer, if there's blood in there, appendicitis. It could be a bunch of different things. Some would, if it's aneurysm, be most life-threatening as we move on down. Here we're showing you other things that could be causing metabolic issue, causing them to have this, some vomiting going on. So we got a differential that we're working with. Let's go on to history of present illness. Again, some of us might be diving in this way. Some of us might be diving into sample, getting the past medical history, meds, any allergies, and some of us might be getting an exam and just kind of looking and palpating there in a quick set of vital signs. We want to make sure that whatever you do, we're trying to do this in an organized fashion. So it's 1 out of 10, 1 hour ago. Doesn't seem to be getting worse. Epigastric now right lower quadrant. Sounds like more appendicitis. But, you know, upper quadrant to the right lower quadrant, mid epigastric. You know, so here we got the pain. Meds, none. Last menstrual period 3 months ago. Could she still be pregnant? Physician confirmed that she is pregnant. So looking at 3 months and, you know, possibly 3 months pregnant now. So this is the first trimester. Usually if this is the topic, we would have caught this a little earlier, but there still is a possibility that she could be. And let's move on. So could be a foodborne pathogen, and she just ate. Some quick set of vital signs. Tachycardic, SAT's great today. CO2, respiratory rate, everything seems okay. We got a slight grade temperature going on. Continue with the rest of the exam. And we see some rebound in the right upper quadrant. And what do we think that could be going on there? As we think, you know, female 40, fertile, kind of think about some of those things. We're moving towards that area. Blood glucose is 90. She didn't have any issues with that, just, you know, no medications. Sinus tach, 12 lead is normal. They're looking at doing an ultrasound to find where this embryo has implanted and where the fetus might be developing. Is it intrauterine or is it outside? Okay, isn't a topic. Now, we got just an EKG strip. I'm not really sure why just a strip would give us anything. It's not diagnostic by any means because it's not the 12 lead, and we know it's sinus tach at 110. So let's move on. What are our differential diagnoses here? So here it is, using the same differential. Now we can change some of these. I hope that we're starting to think about some of these and rearrange them as we move forward. You know, they can do a ultrasound for fetal development. We can look at for CT scan. We can do other things as we move forward. But in the pre-hospital setting, what are we doing to look at? Now here they're giving us possible diagnosis. So here we go into what we thought it would be female 40, fertile. Here they're showing you pictures of the gallbladder. Here we have a inspiratory arrest when we have the patient then take in a deep breath, and as they exhale we place our hand underneath that right hypochondral area, and as they decrease their exhale, the liver comes down against our fingers and the gallbladder sits underneath there, and we have them stop because of their severe pain. So it's positive Murphy sign, acute cholecystitis. Now basic life support, what would we be doing for this? What about our ALS interventions, any critical care interventions as we continue to move on and work our patient up and transport them to the hospital?